immediately scrapped the necrotic tissue and irrigated the corneal cap stroma bed interface with amikacin without opening the cap. And smear examination showed gram-positive cocci. The patient will administer the intensive topical antibiotic therapy every 20 minutes and systemic antibiotic. But the infiltrate in the central part of the cornea had increased. So the cornea cap was opened to fully scrape the necrotic tissue and rinse with ceftriaxone. On day 7, the patient reported a decrease in pain and photophobia, so they stopped the systemic antibiotic. After 1 month, the infection has been controlled. They tapered out the topical antibiotic to once every 4 hours and add fluoromethaline. After 1 year, the cornea showed residual stromal scarring, and the UCVA improved to 2032 and 2025 in the right and left eye. The last play is bilateral smile performing for an 18-year-old man with UCVA postdoc was 2020 in both eyes. On postoperative day 1, he had pain and decreased vision with some round white corneal infiltrate at the corneal cap stroma bed interface in both eyes. They increased the frequency of topical antibiotic administration to once every 30 minutes and irrigated with vancomycin. The control of the washing fluid review Streptococcus pneumoniae in the left eye. However, the symptom continued to worsen and with reduction of the VIs to light perception in both eyes. So the patient was administered intensive treatment with topical levofloxacin and tobramycin every 20 minutes, intramuscular for cefamazine injection and oral levofloxacin. They immediately enlarged the incision. The bilateral corneal cap was opened to fully scrub the infiltrate and then rinse with ceftriaxone. And 2 days later, the right eye improved, but the infiltrate in the left eye was not under control. Therefore, they repeat the irrigation antibiotic and scrape the infectious for the left eye. The patient showed the improvement after that, and topical fluoromethaline was applied in both eyes 3 times daily from 1 month away. And at 6 months, the UCVA improved to 2025 and 2032 in the right eye and left eye respectively. So in all of 5 cases, the symptom onset occurred early on postoperative day from 1 to 3, and all the control results in the report show gram-positive cocci that are commonly found in the conjunctival cell. And the VI on arrival was severe, but the final result was so impressive. So, SMILE is a neurosurgical method, so there is limited evidence in managing bacterial keratitis after SMILE. And it is very important to treat the prompt and aggressive management of vision-threatening bacterial keratitis after SMILE. So for patients with mild infection, topical antibiotic can first be applied. If the infection cannot be controlled, we need to open the corneal cap and converting the cap to flap without delay, scrape and use for smear and control test. And after that, we have to rinse with the antibiotic and maybe systemic antibiotic if necessary. And after infection control, the appropriate and reasonable application of corticosteroid eye drop is required to reduce corneal scar formation and restore vision to the maximum extent. So, bacterial keratitis following SMILE is a rare but serious vision-threatening complication, and system onset occur early on post-operative day 1 to 3. The control result are gram-positive cocci, and the different treatment options depend on the severity of the infection after SMILE. For severe infection, the corneal pocket should be opened into the flap and rinsed with antibiotic at an early stage. And this is the end of my presentation. Thanks for listening.
Thank you very much for your talking about complication after refractive surgery. There's any question or comment for Dr. Kim? Yes.
Thank you very much for very interesting presentation. I think this presentation threatens the surgeon who are doing refractive surgery, even though it's very rare, but it's very dangerous because the patient will have a refractive error is very young. So when there is some complication for them, it's very severe. And I think the first thing that you have to differentiate between the inflammation reactions and infections for this patient, because for the refractive surgery, in the first day, in some patients there are maybe very intense inflammation, and like the sign you showed here. And the most important symptom is the painful. For the inflammatory reactions, it's no painful. But if the patient have a painful, you have to be careful. Maybe it is the infection. I have a question for you. For the old case, the cause is the cocci positive, gram positives, but they use the anti-inflammation, antibiotic, levofloxacin or tobramycin. It is most sensitive to the negative, gram-negative bacteria. So, is there common? What they show?
Actually, I wonder that question too, because I think that bergamot is more the gram-positive is more sensitive with bergamot. But I can't find out why they use levofloxacin, and there is no common noted in the discussion. So that is the question I really wonder, and I really want to ask you.
Because even though levofloxacin have a wide product, but antibiotic, but it's more sensitive to the gram-negative. So in the case we suspect that it causes by the gram-positive bacteria, we should use some other antibiotic. It's more sensitive, like maybe mosifloxacin and vancomycin or some others. But the finally is good.
Okay. For my experience, I use refractive surgery more than 24 years already. And I also meet some patients which after refractive surgery they have an infection. And I remember nearly about 20 years ago I used a LASIK surgery for one young girl. She's a cabin attendant person in the Vietnam Airlines, and she have an infection with after surgery, and at the time I have to take open the cornea flap, and I wash by antibiotic, and after I use general medication, and also I go, and after 1 or 2 months or 3 months later, she vision is good, improve. So nearly is 0.9. So that means almost post-surgery give you a treatment very quickly. So the vision is recovery good. And for the smile surgery, although I maybe sometimes with very few, maybe for percentage 1 on 10,000 cases maybe, and 10 or 20,000 cases, but very with not severe, very mild. So we can still agro and also general medication, and after a few weeks or few months later, the vision will be recovery quickly. And how about other question? Yes.
I think for the infections after the smile, the bacteria is the best prognosis. In my department, we received some patients have infected with acanthamoeba and fungus from the other doctor sent it to us. It's very severe because, as you know, that the infection starts in the cornea pocket. It means that the microorganisms is very deep in the stroma. So for the antifungal medication or antibiotic medication, it's difficult to penetrate to the stroma cornea. So in this case, a very poor prognosis. Yeah. And the bacteria is the very best. The best prognosis is called the antibiotics. It's easy to penetrate in the stroma, so it's easy as well.
I remember that almost in my case, very few case have infection, but when you manage quickly, and often the vision recovery very good. But I remember since a long time now, about more than 10 years, and Dr. Tiếng Anh, he has one case, he surgery for LASIK surgery in another hospital, in the next hospital, high-tech hospital. And he have an infection for both eyes. This patient will come from Japan. So after they complain that after they have to come back to Japan to do have a cornea graft, and it's an awful memory for the old doctor for with the LASIK surgery at the time. Because I know that as a high-tech hospital, at the time they said that they do sterilize for the microcarton is last week, and after about a long time, about 4 or 5 days later, and they take out the microcarton and to do the LASIK surgery patient. And maybe the microcarton is take for a long time, as we have a contamination with bacteria, and this patient have affect all the time, and they have to do cornea graft. I heard about this since a long time already.
For the infection, we have two types. The microorganisms invented during the surgery, like the KU shows. It's very deep in the stroma, and after surgery, maybe it starts in the incision. And the microorganisms invented during surgery, it normally in the cornea conjunctival sac area or from the eyelids when you don't adhesions well, and it invented in during surgery, because in instruments this infection well, it's normally caused by the gram negative, and from the conjunctival sac area or from the eyelid, normally is caused by the gram-positive bacteria, like the KU show.
Thank you very much. And there's any question or comment for Dr. Hien? Bravo again for you.